morning, everyone, again. Thank you for being with us. We have a great speaker today, Dr. Sharon Savage. She is the director of the Clinical Genetics Branch and Clinical Director of the Division of Cancer Epidemiology and Genetics at NCI. I had the privilege to meet with her, and we have been colleagues for the ASH advocates. And we can go ahead and get started with the first case. So this is a 45-year-old male patient presented with interstitial lung disease. And this was a newly diagnosed condition. And he also noted to have mild to moderate cytopenias on CBC. And so patient referred to hematology with elevated MCV. Eventually, after the all unremarkable extensive cytopenia workup, the patient had a bone marrow biopsy. The bone marrow biopsy showed 20% cellularity without any morphological abnormalities, and there was no blast, and cytogenetics was unremarkable with no MDS fish abnormality. So the patient had the previous medical history of avascular necrosis at the age of 32, and the patient was a former smoker where he stopped smoking 15 years ago. Patient family history-wise, mother had non-alcoholic, non-infectious liver disease and thrombocytopenia by the age of 60. And maternal aunt had MDS that evolved to AML in early age at 50. Patient has two healthy siblings, 38 and 42-year-old, and three healthy children, 10, 12, and 15.
So I made a couple little changes to the case because I thought I wanted to kind of bring out a few points, and this is actually very similar to a case that we've worked with. So in the case, the genetic testing showed a TERT variant that I've put in a significant one, and we're going to talk about variant curation kind of at the end of the talk, and I also put, this is a typical for a patient who has interstitial lung disease and a TERT germline mutation. This is a typical telomere length result that you would see, kind of right around the first percentile for age, which is this bottom line. And sometimes they'll be closer to the 10th percentile, which can make the interpretation a little bit challenging, especially for the middle and older aged individuals. And I just wanted to point out here that because we've had some cases happen this way as well, is that in many ways, of course, bone marrow failure syndromes are challenging to diagnose because we're actually testing the affected organ, right? Usually we're doing blood DNA testing. And I just also wanted to point out to the group that saliva, DNA from saliva or from buccal swabs usually is upwards of 50 or more % lymphocytes. So just doing a saliva or buccal collection does not obviate the need for a potential skin biopsy if you have any question about the variant allele fraction, especially if it's a heterozygous variant that is often seen in the somatic situation. So kind of, I think we sometimes shy away from skin biopsies, but they're quite easy. They're not that painful. And sometimes we'll coordinate that with the bone marrow. So you just take a little skin biopsy next to the bone marrow biopsy site. So we obviously are thinking about a telomere biology disorder for this patient. And I thought I would start with kind of just a bit of background to remind everyone is that telomeres shorten with each cell division because of the inability of the DNA polymerase to fully replicate that 3' end of the DNA. And there's a host of proteins that either bind to the telomere, near the telomere, interact with each other, and also the telomerase enzyme complex, which extends telomeres in a reverse transcriptase manner. So telomere biology is very complicated, and one of the things I really like to emphasize, because a lot of what we do in the TBD world overlaps with what you see in the telomere epidemiology world, but there's quite a lot of differences as well, is that maintaining telomeres is really a dynamic balance between interconnected intrinsic and extrinsic factors. And genetics are, of course, part of that. But in the general population, environmental exposures, including cigarette smoking, other oxidative stress factors have been associated with telomere length differences. And then laboratory methods really matter when we're measuring telomere length. So these are just all things to consider, and really emphasizing that telomere length is a balance of across all populations. So one of the things I wanted to point out, and sort of building on that, is what we're talking about here are patients who have usually very short or short telomeres, meaning less than the first or 10th percentile for their age. And they have very rare germline genetic variants. So these are variants that you don't see in the general population. And the genes affected in the telomere biology disorders really affect the telomere in and of itself, in that there's something dysfunctional, whether it's a sheltering component that affects how the telomere is capped, or the inability of telomerase to actually do its job and extend telomeres as needed. But at the other end of the telomere length spectrum in the rare disease setting, there is what we're now calling the set of disorders called cancer predisposition with long telomeres. And these are people who have rare germline variants in some of the same genes that we see in the TBDs. In this case, it's more likely to be POT1. Sometimes we'll see TRK2IP, ACD, even TNF2. And these are patients who are at increased risk of certain cancers, including melanoma is the most common in this setting, sarcomas, CLL, even some AML has been reported, non-Hodgkin lymphoma. But these are patients who don't have the phenotypes associated with the telomere biology disorders. And their telomeres, although they have these mutations, in general, the telomeres are functional. They're longer than they should be. And we think that really allows more replicative capacity for the cells. And then I just want to point out, because sometimes there's this kind of blurring of areas where we also know, as far as regulating telomere length, there are many common genetic variants. So SNPs with a minor allele frequency more than 1%, where there are case control or case cohort association studies showing that telomere length, whether it's measured or genetically determined based on a polygenic score, is associated with risk of certain diseases in the general population. So in this case, long telomeres are associated with lung cancer, kidney cancer, glioma, but that by long, we're still talking telomeres that are usually going to be between the 10th and 90th percentile in populations. And these are small changes in telomere length. They're not like what we see in our patients with TBDs. So in thinking about what's happening as this telomere balance, I also wanted to point out the idea that, in general, we used to sort of always say, well, telomeres get short with each cell division. They get to a critically short length. The cells are either undergo senescence, which actually is not a good thing. It's very pro-inflammatory, or apoptosis. And then that's sort of, you're done. And then we would think that, okay, if that doesn't happen, if cells can upregulate P53, TERT, other components, they continue to divide despite having genomic instability from short telomeres, and that, you could imagine, sets you on your way to carcinogenesis. There's really now this appreciation that increasing, even in cells that don't reach a critically short telomere length, if they get there and they upregulate telomerase or the alternative lengthening of telomere pathways or other mechanisms, they increase their telomere length and can continue to divide. And these are cells that maybe should have undergone apoptosis, but because they're able to extend their telomeres, they continue to divide. Then they're at risk of accumulating additional somatic mutations, which then can put you on that carcinogenic pathway as well. So in getting back to telomere biology disorders, I like to point out kind of a little bit of the history of these disorders. I think it helps put the patients in context. So this is a classic DC family, which was the first telomere biology disorder. This is a history of a family in our study. And it started with this man who had bone marrow failure at 17 and passed away at the age of 32. He had dysplastic nails. And then he had a daughter who was perfectly healthy, but had 3 affected children. And this was because of the germline variants in the X-linked gene dyscarrin. And the discovery of dyscarrin mutations by Inderjeet Dhogal's group and functional follow-up with Kathy Collins's group showed that the X-linked form of dyskeratosis congenita is caused by dyscarrin and was the first time this was actually connected to defects in telomere biology, because the patient's cells were found to have low telomerase and very short telomeres. So this, of course, continued. And when we look back at the literature, we see that as early as the 1960s, there were female cases reported. And we now know that there's autosomal dominant and recessive inheritance patterns in some individuals who have no family history and de novo variants. But when I sort of started working on this field, we knew that there were 3 genes affected, TERT and TERK, as heterozygote, and then, of course, the X-linked. So Blanche Alter, Peter Lansdorp, and others in our group really were the first to look at telomere length as a diagnostic test for the TBDs. And what we showed at this time was that telomeres less than the first percentile for age were highly sensitive and specific for dyskeratosis congenita. And that was based on what our cohort looked like, again, more than 10 years ago, but with follow-up. And so now there are larger studies, and I think this very much established that flow fish of lymphocytes is the diagnostic test for the telomere biology disorders. And this really has to happen in combination with genetic testing as well. And we'll touch on some of those issues too. But after sort of establishing this as a diagnostic test, we and others were able to basically show that there are many other genes that cause dyskeratosis congenita, and really helped us expand that phenotype to this concept of telomere biology disorders. We now know that there are autosomal dominant and recessive patterns. One of the challenges, especially for the adult hematologists, is that I'm a pediatric hematologist, where we often first see very severely affected children who have autosomal recessive disease, say, for example, in RTEL1 or PARN or even in TERT. And a challenge is, of course, those are young children who have young parents. And those parents are heterozygous carriers and may be at risk of developing some of those isolated features that I'll sort of explain in a few minutes. So we have to really consider the whole family across this. So as we've learned more, the telomere biology disorder community has really come up with some definitions that TBDs are a specific spectrum of illnesses caused by telomere dysfunction. The phenotypes of the patients result from limited stem cell renewal induced by critically short telomeres. And we also now know, and this is why short telomeres isn't necessarily the best adjective for these disorders, because there are some telomere biology disorders in classic settings, including Hoyer-Alr-Riederson syndrome, that actually don't appear to have telomere shortening, but they have unstable telomeres, and these are caused by mutations in Apollo, and the phenotypes are very consistent with classic GC. So I wanted to also share another case that I thought would be relevant. When I saw your case, it reminded me of this patient. So I thought, and a couple of lessons learned around telomere testing. So in this case was a 54-year-old man who contacted us, and he had had pancytopenia diagnosed around age 45. He had a hypocellular bone marrow, no morphologic evidence of dysplasia or MDS. And he was just sort of followed. He didn't really need treatment at the time. But around 9 years later, his anemia and thrombocytopenia were worsening. He had another bone marrow that again showed trilineage hematopoiesis, although it was reduced, and he had a complex karyotype abnormality. On history, he actually had a sibling who died at age 40 who presented with severe anemia, bleeding, and fever, who was his diagnosis. It sounds like this was quite some time ago now. We don't have specifics, but there was this kind of MDS versus an acute myelomonocytic versus a chronic myelomonocytic differential diagnosis for him that I don't think was really truly established prior to his death. But going back to this case, this 54-year-old man, his physician contacted us and said, I'm suspicious based on the history, but his telomere length is normal. And I asked them to send me the results. And it turns out they had measured them by qPCR at a company, and his telomere lengths were, according to this company, in the 25th percentile for age. And I said, we don't really like telomere length by qPCR is complicated. There's some issues there. Let's look at his flow fish. And doesn't look great because it's a screenshot of a fax report, but you can see at repeat diagnostics, his telomeres were more close to the first percentile for his age. It turns out the patient has a germline Turk mutation that was confirmed by skin biopsy. That's consistent with the phenotype. So I just wanted to point out a couple of things about qPCR because we wanted to mention telomere length diagnostics. And qPCR telomere length testing can be a really good tool for very large population-based studies. So for example, we have done this in tens of thousands of patients. The UK Biobank actually has qPCR data on around 500,000 participants. And that's because it's in a robust, highly reproducible assay in specialized labs. And we know that qPCR telomere length testing is affected by DNA extraction method, DNA storage. You have to run your controls at the same time you're running the cases. And we and others had shown that it's really not a sensitive or specific test for diagnosing the TBDs. So I just wanted to point that out. So FlowFish is still what I consider the standard of care for diagnosing telomere biology disorders. I did want to bring everyone's attention, though, to what I think has potential. It hasn't been used in the States yet, but Duncan Baird and Indrajit Dokal published this paper a couple years ago showing that using a method that's called high-throughput STELA, which is single telomere length analysis, and it measures the single telomeres they're using chromosome 17p as a test. And they are now have shown that short telomeres looking at 17p telomere length is highly sensitive and specific for diagnosing TBDs. And they now in the UK are using this as their diagnostic test. So I think there's potential. One of the nice things about this is you can use DNA. You don't have to send fresh blood cells. So there's potential changes. But again, right now, I think FlowFish gives us the most information. So now I'll talk about the kind of the spectrum of TBDs and kind of try to put some of this in context with that first case. So classic dyskeratosis congenita, which is really the first TBD, has this mucocutaneous triad of abnormal nails, dysplasia, skin pigmentation, and oral leukoplakia. I will say, though, this is tricky because not everyone develops these features at the same time or at the same rate. What I've also seen in usually more in middle-aged men, when you talk to them more, it's like, oh, I've always had bad nails, but sometimes they're like a farmer or a construction worker, and they're like, yeah, I use my hands, my nails are just crummy. Turns out it actually could be related to an underlying TBD because then they are presenting later with marrow failure, for example. Hoyer-Alr-Riederson syndrome is part of the spectrum. It has features of DC plus cerebellar hypoplasia and immunodeficiency. Coates plus is considered part of this as well. It's usually caused by biallelic mutations in CTC1. These are patients who also can have exudative retinopathy, massive GI bleeding due to vascular telangiectasias and bone abnormalities. And then Revenge syndrome, usually caused by heterozygous TNF2 mutations, has similar overlapping phenotypes, but includes this bilateral exudative retinopathy. These are usually kids who present very early in life, and their telomere lengths are usually very, very short for their age. And they're pretty easy to, quote unquote, they're easy for me to look at and say, yes, they're a little harder to diagnose in the clinic because their presentations aren't always typical. And these are patients who usually have autosomal recessive disease, X-linked recessive, DKC1, or de novo heterozygous TNF2 mutations. And we know I'm going to show you our genotype phenotype data in a little bit. Then we have the patients who are more likely to have an isolated feature and present as adults or middle age or even older sometimes. And these are patients who might present with aplastic anemia, myelodysplastic syndrome, or even early onset, meaning less than around 40 or 50 head and neck squamous cell cancer without risk factors. These are patients all who, of course, should have chromosome breakage done to rule out Fanconi anemia, because similar to the TBDs, there are patients with Fanconi anemia walking around out there who don't have those classic dysmorphic features. And then, of course, patients might present with pulmonary fibrosis, interstitial lung disease, liver disease as well, like our case. And these are patients who are more likely to have telomere lengths in that 1st to 10th percentile. And that's where some of these can be a little bit challenging and where genetic testing is important. And when we look at these patients, they are more likely to have heterozygous variants and an autosomal dominant inheritance pattern across many genes now, but the most common being TERT, ARTEL1, and PARN. So I thought I would talk in the context of this patient. So we mentioned that our case is a 45-year-old male with interstitial lung disease. So I wanted to show some images. The images below are a woman we followed for about 25 years with a TERT mutation. And she developed shortness of breath. She had had longstanding marrow failure that was not managed with androgens, but unfortunately she developed pulmonary fibrosis, and you can see the progression over 3 years, and that is unfortunately what she passed away from. I want to point out that it's not just the adults at risk or who get pulmonary fibrosis. This is a lung biopsy of a 13-year-old. I'm sorry, this is actually an explanted lung of a 13-year-old with a TNF2 mutation who had had a successful marrow transplant around age 6 and went on to get a lung transplant around age 13. So coming back to our case, and what do we do? How do we treat this patient in thinking about the ILD? So the data, unfortunately, aren't great on what to do with these patients. The anti-inflammatories, meaning corticosteroids and others, don't appear to benefit patients with TBDs and might reduce survival. And that actually makes a lot of sense because we don't think they have an inflammatory lung disease. There's a couple suggestions that antifibrotics might improve lung function, but they don't appear to have improved overall survival. And it's really not clear how much, a little bit of a lung function improvement really matters in the long run. The other thing is antifibrotics have a lot of side effects, including nausea, diarrhea, which can really make it difficult for the patients to stay on treatment. And danazol, so there was a danazol trial by Neil Young at NHLBI that was published 8 years ago now, suggested there were some improvements in PFTs, but it was a small sample size and the measures are hard to reproduce. So what we really need and what we're working on with the pulmonologists is specific clinical trials focused on patients with TBDs to really sort out what can we do to help improve their lives. We do know lung transplant works, but these are patients who are at increased risk of cytopenia complications. So, as I said, lung transplant will likely exacerbate their cytopenias. But when we think about this case and his cytopenias, right now, they're mild to moderate. Does he really need treatment now? And how do you balance that in the context of his lung disease? And how do you follow his lung disease and his cytopenias? So I wanted to show a little bit of data around bone marrow transplants. So this is based on a couple of different studies showing that basically years and years ago, outcomes after transplant for dyskeratosis congenita or TBDs were not good. This is a systematic literature review that shows some potential for improvement. And I do want to just point out that the reduced intensity conditioning has made a huge improvement in the outcomes for patients with TBDs. The first study, this was published from Jacob Tolar's group at Minnesota in 2011. That group did a similar follow-up that just came out from Kristen Evans and Jacob. They compared their patients who got Cy, flu, alemtuzumab plus or minus TBI and showed some improved outcomes without, and that TBI is not needed. Sunit Agrawal has been running this study using fludarabine and alemtuzumab, and it's been, I think they're upwards of more than 10 years of follow-up and 40 patients, and that study is being written up now. And I would say anyone who has questions or comments about what to do with patients rather around transplant is that Sunit Agrawal would be my main point of contact for those questions. So then we say, well, what if patients don't need or aren't ready for a bone marrow transplant? What can we do? So we've known for decades that androgen treatment can improve cytopenias in patients even with acquired aplastic anemia and Fanconi anemia. The first cell line to respond is usually the red cells, but then sometimes we see thrombocytopenia improvements and even occasionally white cell improvements. These are patients who the androgens, they respond, their counts don't normalize necessarily, but about 70% can become transfusion independent. And so I see androgens as a bridge to transplant for a lot of patients. There are, of course, concerns because they can be hepatotoxic, and liver ultrasounds and LFTs need to be followed. There's some reports of patients who have gotten G-CSF and androgens who have had splenic rupture. And then we also have to follow the lipid profiles very carefully. We've seen increased cholesterol and triglycerides significantly. Now, the attenuated androgens, where most of the field is focused on danazol now, have fewer side effects and appear to be better tolerated. So one of the hypotheses is that androgens increase telomere length by potentially increasing telomerase activity because the TERT promoter has an estrogen response element. And there are preclinical studies that suggested in cell lines and in a mouse model that telomere elongation could occur with androgen treatment. But it's also not clear, especially around danazol, if this is actually the mechanism, because it's danazol and its metabolites are not actually capable of being aromatized into an estrogenic metabolite that could activate an estrogen receptor or estrogen response element. So I think the mechanisms are still, an active area of study, and as is the role of androgens and telomere lengthening. So we did an observational historical study where we looked at patients who were on androgens and not on androgens, and we didn't see a difference in whether androgens lengthened telomeres. The clinical trial of danazol suggested that there was a lengthening that happened during treatment, and then after you took the danazol away, telomeres shortened again. And then this other small study also suggested that flowfish telomere length might lengthen telomeres. But I would say, again, all of these studies are limited by sample size. And so now, if anyone has patients to refer, and who would consider low-dose danazol study, Emma Grocki and Neil Young's group at NHLBI is leading the study of low-dose danazol for telomere-related diseases. So definitely contact her if you have a patient who you think might be, you might want to consider treatment. There's another study that Rodrigo Collado is leading in Brazil, and they've actually published this using nandrolone instead of danazol. So going back to the hematopoietic manifestations of the TBD, somatic mutations, I will say I'm not going to go into this in detail. It's really complicated. There's a lot of new data coming out. But I wanted to point out that we do see clonal hematopoiesis in the TBDs. We do see that there are acquired somatic mutations, and it's an area that we have a large study that's undergoing revision with Neil Young's group and with uh, many others across the country looking at this in a more comprehensive way. And this is one topic where the consortium, the Clinical Care Consortium of Telomere-Associated Ailments, is really working on combining data because there's several studies. And so I think right now we're following and we're looking, but we can't make specific treatment recommendations until we have more information on acquisition of somatic mutations in this context. I do also want to point out that there are some benefits with and some direct somatic germline rescue in patients with TBDs. So there are several reports now where patients have basically had a correction of their germline mutation. And I just point you to this great review by Patrick Revy and Alison Bertucci that really does a nice job of combining everything across what we know for TBDs. There are also reports where patients more commonly have acquired a TERT promoter mutation that allows increased activity of telomerase and has appeared to has helped improve blood counts in patients. So I think, as I've said, we really need large long-term studies of patients with clones in their blood. We don't have any idea whether these clones arise in other tissues because we haven't been able to study those. And I think it's a really important area. And I think in the next year or two, we'll be able to be a little bit more definitive in recommendations. So I know I've talked a lot about different phenotypes, and I did want to also let everyone know is that the Clinical Care Consortium for Telomere-Associated Ailments, the CCCTAA, which was co-founded by Sunita Agarwal and myself about just over 10 years ago now, has really brought together people to try to understand these phenotypes in more detail. And if anyone is interested in getting involved, please contact me. We're welcome. Right now we have collaboration agreements signed with 22 institutions around the world, and we're always looking for more. You don't have to have many cases. We're just looking for people who are willing to share data and work together. So we looked at vascular complications, pulmonary arteriovenous malformations, GI bleeding, and telangiectasias. And I did want to point out, because this patient had a relative with a history of liver disease. So liver transplant in the TBDs is, of course, complicated because some of these patients have actually already had a bone marrow transplant, or we know their blood is at risk of their marrow has a low reserve. So what would happen to them if they needed a liver? So what the consortium did, this was led by Cass Myers and Michelle Wong at Cincinnati Children's. They looked at, across the consortium, 83 patients who had a TBD and liver disease. There were 17 participating institutions. And of those patients, after they combined, there were 40 patients who were evaluated for liver transplant, 28 were listed, and 20 underwent a liver transplant. And of the 11 not listed, they were either declined by the center, by themselves, and one because the severity didn't appear to be severe enough at the time. And what we learned from this retrospective case series was that the TBD patients actually did not exhibit excessive post-liver transplant mortality. They had improved respiratory status in many patients. And our recommendation was that the diagnosis of a TBD should not exclude the consideration of a liver transplant. So if folks have any questions about that, I would encourage you to take a look at the article. And again, we're always happy to talk about cases. So I also wanted to touch on, the patient that we presented as a 45-year-old male with ILD and a heterozygous variant, I've talked a lot about disease heterogeneity and how do we use all of that, because it gets really complicated really quickly. So one of the things that we looked at with Marina Nivich, who is a clinical fellow in my group, who's now on faculty back at Hanover in Germany, looked at our study cohort of 231 patients, and she grouped them. We have a clinic cohort, which are patients we've seen at the NIH Clinical Center. We also have what we call our field cohort, because we do epidemiology as well. And these are patients who are fully enrolled, fully consented, who have shared the same data, the same medical records, done the same questionnaires, even shared biospecimens. They're just patients we have not actually seen at the NIH Clinical Center. So our clinical phenotyping for those patients is based on medical reports. Whereas the clinic cohort, we have comprehensive phenotyping. But you can see we have a good range of the types of mutations in the patients, with around half having heterozygous disease that's not TNF2. And when we looked at the field and clinic cohorts together at their overall survival, you can see here that the median overall survival is in the early 50s in our cohorts. But it's lower in males. That's likely due to DKC1 mutations, which we know presents earlier in life. So then we really struggled sort of, how do we actually do a proper genotype phenotype study in a cohort in a disease where we have multiple modes of inheritance, multiple genes affected. And we decided to say, let's look at the heterozygous, so the autosomal dominant inheritance, but not TNF2, because we know those are often present very early in childhood and are usually, not always, but usually de novo variants. So we grouped all our non-TNF2 dominants, compared those with the autosomal recessive and X-linked recessive disease, and looked at TNF2 separately, and then those with our unknown genotype. And what this shows is really quantifies what we knew in the clinic. Our patients with heterozygous disease, like this case we started out talking about, are more likely to live longer, with their 50% survival probability is in the 60s. Whereas our younger patients present earlier in life, and of course, unfortunately, their overall survival is much poorer at younger ages. We also looked at this in the context of adjusting for telomere length. And what was significant is that really we didn't see a huge difference, whether we accounted for telomere length or just looked at the genes itself. And that is, we know, because the telomere length is correlated with the gene that's affected, right? So, but I just wanted to show that we looked at this to really make sure to assess kind of all the variables. This is unpublished data that's under revision right now, that I hope we'll have the revision submitted in a few weeks. But cancer and the telomere biology disorders has been something we've really been working hard to quantify since our marrow failure syndrome study opened in 2001. And what I put up here to compare and contrast is, so Blanche Alter had published the first study of cancer and dyskeratosis congenita around 2009, 2010. And then in 2018, we looked at it with 15 years of follow-up in our cohort, and we compared the incidence of cancer in our patients with that of age, sex, ethnicity, and year of diagnosis matched controls in the NCI-SEER data. And so we asked how many cases were observed in our cohort versus how many are expected in those matched patients. And what we found was that patients are about a fourfold increased risk of any kind of cancer, with tongue cancer being predominantly a high risk, and AML and MDS, of course, also high risk. The tongue cancer risk appears to go up after transplant. It's really hard to say cause and effect, right? Because these are patients who got a transplant and now are living longer because they don't have their marrow failure issues. But transplant could also have an effect on subsequent malignancies. Now, what Marina and I have done now is we have more patients, more after any organ transplant. She included liver and lung as well. And you can see we're kind of getting to refined risk estimates, but still high increased risk of certain cancers in these patients. And then Marina also was able to look at cancer This is looking at transplant and cancer-free survival by mode of inheritance, similar to when we looked at overall survival. And what we see is also that our autosomal dominant patients are likely to have a later onset of cancer or needing transplant compared with the youngers, with the TNF2 and recessive disease. And so, again, these are things that we're trying to work on refining these estimates to better guide patients like this, the 45-year-old man with new ILD. And so I wanted to come back to this, and this might not be the perfect pedigree, but this is of this exact patient, but I think it's probably pretty close. And he reminded me again of many cases like this. So in this example, we have this 45-year-old man who's clinically affected, who had a clinically affected mother and aunt who didn't have genetic testing, but we're kind of suspicious they probably were also variant carriers. Now, he has healthy siblings and healthy kids, but he has this TERT variant. So what do we do with his relatives? Okay. His siblings are at an age where they may be, if they're carriers, at risk of these diseases, right? And then his children, who are right now healthy and young, but also could be carriers. And a challenge with the TBDs is that genetic anticipation is a factor. So what we see, what that means is that in some pedigrees, we see that there is earlier onset of disease and shorter telomeres in subsequent generations. And so could this 45-year-old man with ILD and cytopenias, could one of his children actually develop marrow failure in their 20s? It's possible, it's been seen. And those are the kind of things we need to think about. So I really want to emphasize, because we're also busy in clinic, the importance of genetic testing and genetic counseling, because there's a lot of uncertainty in these families, and uncertainty about the penetrance, about the phenotype, the autonomy of the kids, right? These are kids who are getting close to adulthood, who will have a say in this disease. It can change family dynamics, right? Survivor, quote unquote, guilt is a big issue in some families. And so these are things that the genetic counselors really can help families work through. And I can't recommend that strongly enough. And this also, one of those uncertainties also comes into variants, right? So I think the actual case may have had a VUS and a variant of uncertain significance. And the curation of germline variants is, of course, incredibly important because, as I said, knowing if you have a likely pathogenic or pathogenic variant changes everything about what you thought you had or didn't have in yourself and in your family. So the American College of Medical Genetics and Genomics has standards for how to curate variants in genes. Now, I will say that in the TBDs, majority end up in this VUS category. So what are we doing about that? And also seeking people who are interested in this in more detail. So ClinGen has a wide array of curation activities with really the goal is to do comprehensive, detailed, gene-specific curation for genes associated with disease. And what I brought up here is there's really two efforts. One is a gene curation that I'm going to talk about. The other is variant curation. Okay. So just in the less than a year, really, led by Christine Garcia, who's at Columbia University, who's a pulmonologist and expert in TBDs and ILD. So I'm participating in this group, and this is a gene curation expert panel. And basically what they do is we take all of the genes that have been associated with ILD, and a detailed literature review is performed. And the question is not about the variant, but the question is there enough evidence that this gene is associated with this disease to say, yes, that gene, if you have variants in that gene, you're likely to have this disease. And so this is what we're going through now and looking at the validity. that sometimes clinically seems obvious to us. Like if you told me TERT was an interstitial lung disease gene, I'd say, oh yeah, of course it is. But this is a way to really pinpoint that and use the evidence to define those genes. So that's underway. And if anyone's interested, here's more information. Once a gene is established as really being part of that disease phenotype, the next step is actually a variant curation expert panel. And so this is where you take that gene that you say, we know this gene has variants that causes disease. Now let's look at each specific variant. And the myeloid malignancy panel is going to be moving into looking at TERT and TERC variants in context of myeloid malignancy. So these are things that are ongoing, things that we're participating in. And again, if folks are interested, I'm happy to help talk through what might be some options here. What we did and I encourage everyone to take a look at Marina Naivich's paper in Blood from 2022. Look at the supplement. She, in working with her and our bioinformaticians, we adapted the ACGME criteria to the TBDs, incorporating as best we could telomere length data from our cohort and other cases. It's not perfect, but I think it's a good starting point and will kind of be the basis for these future variant curation efforts. So I'm going to end a little bit with coming back to some of the consequences related to that this case is dealing with. So living with a telomere biology disorder is complicated. It can be much more than quote unquote just marrow failure or just ILD. They're at risk of these complications. And again, I refer you to this review, which is outstanding as a way to look at everything. So I wanted to just touch on a couple things from our psychosocial research team here. And this is a quote from a patient who participated in a qualitative interview study led by our psychosocial team. And she says, what is actually having short telomeres? I mean, what does that truly mean? If I can't generate new cells, what does that mean in the timeline of your life, right? These are the kinds of things our real patients are thinking about. And I feel like this is very profound for us to consider. And this study is currently under revision. And again, hopefully we'll hear soon. And in our psychosocial needs assessment, we found really that the adults and the family caregivers of spouses or children with TBDs have numerous challenges across basically all domains of life, including mental health, physical health, financial needs, school support needs, et cetera. And that one of the most profound difficulties was care coordination to manage these multi-system complications. And I found this to be even more profound in the adult world. Of course, I'm a pediatrician, so I'm a little biased, but in many ways, the pediatric kind of world, I think, it's not great, it's not perfect, but they do a pretty good job of helping these patients coordinate care, especially if they've needed a transplant. In the adult world, or as the kids transition into adult, it often gets really complicated. And we really, I think, need to work as a community to help these patients develop their medical homes with that care coordination, because there's so much to think about. And these gaps may pose psychosocial risks that can affect the healthcare outcomes, quality of life, and psychological well-being. And in fact, I would have a really low threshold for referring patients to psychiatry or psychology if they're up for it, because we've seen this as a challenge for them. And so I want to point you all to, I hope you've seen it, and if you haven't, here it is that this is the second edition of the TBD Diagnosis and Management Guidelines. You can download it for free at teamtelomere.org. That's the patient support and advocacy group. We work very closely with them. And I also recommend that you refer patients to Team Telomere if they're interested, at least give them the website. They have a lot of really valuable information there. They have folks who can help with support and connecting them with experts. You can also, if you want a physical copy, you can request the physical copies for yourself and your patients as well. And with that, I will end. And thank you very much for the invitation. I don't know if we truly solved your case, but I think there's a lot of things to think about and for him moving forward.
Great. Thank you, Dr. Savage. So just, I mean, excellent overview, excellent diagnostic treatment approach. I really appreciate your insight. So when you mentioned about low fish panels, do you want to touch base on that? Where do you send? Do you usually send for validated centers, or does it really matter when it comes to flow fish methods?
For gene panels, was that the question? The genes?
For telomere length
Telomere.
analysis.
So
Yes.
we use repeat diagnostics, which is based in Vancouver, and they do have US CLIA certification. But sometimes that's an issue with certain insurances. And we use them because they're really who we've worked with from the beginning and had developed the diagnostic test back around 2005 or 6. And so what we usually do is a couple things to actually point out is that total lymphocytes are the most sensitive and specific for diagnosing TBDs. Granulocytes are not as specific. We often see they're short and they're not really always helpful. I actually don't even often look at them. The lymphocyte subsets that repeat diagnostics can do can be helpful, but in many ways they don't necessarily push me one way or the other in a diagnosis. I think they're helpful if you're thinking through patients who have might have immunodeficiency or even MDS, is sometimes we'll see a skewing. But that has not been systematically studied at that, like the multi-panel. Hopkins also does the flow fish looking at lymphocytes and granulocytes. They don't do the 6-panel. And we've seen results from those patients as well, and they do a good job as well. So that's what we prefer for the flow fish testing.
And then, with having these testings available, most of the ILD patient will be tested for telomere biology disorders with the flowfish method, and they will be reaching out to hematologists. Hey, I know cytopenia is not the problem, but this patient had this macrocytosis for years. Do you mind to get the bone marrow biopsy done just to make sure the patient should not get the transplant or get the transplant with the CMV status, different status. So what is your approach for those kind of, non-severe or mild cases with the
So
cytopenia, but
yeah.
obvious ILDs or liver cirrhosis?
So what I usually recommend for is someone who's presenting with ILD or liver fibrosis and their blood counts look pretty much okay. Yeah, like you said, maybe an elevated MCV. I think in general, the field, we like to get a baseline bone marrow evaluation, mainly to sort of have a baseline and know where you're starting from. And then if the patient's counts start, and then following the CBCs, at least annually, and again, depending on the patient's situation. So if they have progressive liver disease, obviously I would do CBCs more often. Same if they had progressive lung disease. The issue, though, I could see is that doing a bone marrow, chances are they're going to be hypocellular, right? Like it's probably going to be the case. And so would that scare a pulmonologist or a hepatologist away from considering them for transplant? And I think that's where having these close working, collaborations and discussions. So, the liver study that we did with the consortium suggests that it's not an issue, that they can go on and have a successful liver transplant, but they might need support through that. So it's always a balancing act, but I do think that a new TBD diagnosis should have a bone marrow just at baseline at some point. And then some people recommend annual bone marrows. I like to kind of tailor that more to what's actually happening with the patient and following the blood counts closely.
Okay, got you. And then you also mentioned about this, TBD related genes to be involved with the myeloid panels. As of now, as far as I know, Tempest and Foundation is not including them. Is that some sort of effort is gonna be streamlined for others as well? Because I
Oh,
didn't get that
yeah,
part.
that's a good question. I don't know. I don't think it's been like a comprehensive effort to make it streamlined across the field. So it's something that we should look at. And the other challenge is also thinking about the other marrow failure syndromes, right? Where some of those genes might be on a somatic panel. And balance, taking that into consideration. I guess I see that more often though in other cancer prone syndromes.
Okay, got it. Does anyone has any question from the audience? Okay, great. Thank you, Dr. Savage, again. This was a wonderful talk. We will be hosting Mary from Hopkins in a couple months, and we will be talking about more of a liver cirrhosis and transplant and how to, stratify this patient ahead of the time. I think this is an unveiled area of everything. I hope that will be another session that we will talk about the telomere disorders and everything. Thank you, Dr. Savage, again.
Yes,
Appreciate it.
you're welcome. Thank you.
Right.
Okay.
Okay. I'll see you at ASH.
Yes, I'll see you then. Okay.
Okay. Bye-bye.
Bye.